Hello, everyone, and welcome to the Liver Health Foundation's free educational webinar on Alagille syndrome. I am Farah Douglas, President and CEO of the Liver Health Foundation. Before we get started, I need to say a few words. We know Los Angeles has suffered a devastating firestorm and now the rain. Our hearts go to those affected by the fires, and we pray for the safety of everyone, and especially those Angelenos in the affected area during this rainstorm that we are experiencing right now. We have had a rough start to 2025, but we know we will come out of it and will be better than before. Now to our webinar about Alagille syndrome. This is a rare genetic disease that affects multiple organs in the patient's body, including liver, heart, spine, eye, face, kidneys, and even blood vessels. This disease can be hereditary and caused by changes, mutations in a gene, or can be new mutations. Most patients with Alagille syndrome have liver disease caused by bile duct paucity, which means a decrease in the number of bile ducts in the liver. In tonight's webinar, we will learn about Alagille syndrome, also known as ALGS, and how it impacts the lives of liver patients. As I mentioned, this is not just a liver disease. It impacts many organs and has a distinct facial characteristic as well. Liver Health Foundation is proud to host these free educational webinars to raise awareness of liver disease and to educate patients. We are a patient advocacy 501c3 nonprofit organization with the mission to support liver patients, their caregivers, and family members. We operate in Los Angeles, Inland Empire, Orange County, San Gabriel Valley, and portions of Arizona and Northern California. In tonight's webinar, Dr. Georgiani will offer a comprehensive review of Alagille syndrome through a PowerPoint presentation. At the conclusion of the presentation, we will begin a roundtable discussion with Dr. Patel and Dr. Chandana. During the roundtable discussion, our experts will talk about their own experiences and or research about Alagille syndrome. If you have questions, please enter them into Q&A or chat functions, and we will try to catch them all. Now my disclaimer. Please remember, information given by our expert is not a substitute for advice by your own physician or healthcare provider. We do not endorse doctors, hospitals, medical centers, or treatments. This program has been made possible by an educational grant from Epson Pharmaceuticals. We thank Epson for their support of our efforts to help liver patients. We also thank Miram Pharmaceuticals for their continued support of our webinars and efforts through their educational grants. It is my honor to welcome back Dr. Georgiani, who has been a great resource for the Liver Health Foundation in raising awareness of liver disease. Dr. Georgiani, MD, FASLD, is Professor of Clinical Pediatrics, Transplant Hepatology Fellowship Director, Associate Director, Pediatric Liver Transplant Program, Division of Pediatric Gastroenterology, Hepatology, and Nutrition, Children's Hospital of Los Angeles. Dr. Georgiani graduated from Ain Shams University College of Medicine, Cairo, Egypt. After completing his internship in pediatric, he continues his residency and fellowship in pediatric gastroenterology at Kaiser Permanente Medical Center, Los Angeles, and University of California, Los Angeles, UCLA. Dr. Yani has been medical director and associate professor pediatric GI at Loma Linda University Children's Hospital, attending pediatric GI at Riverside County Regional Medical Center, clinical associate professor pediatric GI at Keck School of Medicine, University of Southern California, USC. Some of Dr. Yani's other titles include Interim Medical Director, Transplantation Institute, Loma Linda University Adult Liver Transplant Program, Hepatology Fellowship Director, Pediatric Gastroenterology, Children's Hospital, Los Angeles, and Director of GI Endoscopy Services, Division of Pediatric Gastroenterology, Hepatology, and Nutrition at CHLA. Dr. Yanni's major areas of research and interest are pediatric liver disease, gastrointestinal and hepatic autoimmune disorder, transplant immunology, pediatric NAFLD, obesity, pediatric gastrointestinal procedures, and more. Dr. Yanni is a member of the Liver Health Foundation's Medical Advisory Council. Dr. Yanni, welcome. We are excited to have you with us. Thank you for your support and participation, and we are ready for your presentation.
Thanks, Farah. Thanks, Laura, for this wonderful and kind words introducing me. Thanks for the audience. Thanks for the staff attending this lecture. It's an honor and pleasure to be involved in this webinar regarding the liver health when associated with liver health foundations. Today's topic, I'm going to basically touch on a very important aspect of pediatric liver disease, Alagille syndrome. I know that some of the audience, they already sent questions. They have kids or children diagnosed with this condition. Because of our hospital here and the nature of our referral system, we are a large major referral center in Southern California, having so many children with Alagille syndrome. And we have one of the most successful liver transplant programs in the nations. We rank number 2 all over the United States for our liver transplant center here at Children's Hospital, Los Angeles. Without any further introductions, I was going to start my talk about Alagille syndrome. I will, you see my screen now?
Yes, we can see it.
Okay. So Alagille syndrome or ALGS, it is a condition which is basically autosomal dominant multi-system disorders, means that affecting multiple organ system in the human body. It is discovered or described by Dr. Daniel Alagille in 1969. The initial the description or diagnosis was based on several children presented with what appeared to be a chronic liver disease, and found out to have also associated heart conditions, kidney conditions. And when Dr. Daniel Alagille did some investigations, found that the main problem or the main culprit in this condition is the absence of the bile duct, which carries the bilirubin from the liver outside of the liver for the purpose of digestions. And we will know later on in the next few slides why this can cause damage to the liver tissue. The original name was basically named arteriohepatic dysplasia, or some abnormalities in the vascular development of the liver tissue. As I said a few minutes ago, that's major other organ involvement include the kidney and the heart. In addition to, if we want to take it from the head to toe, so the children with Alagille syndrome, they can have eye abnormalities. They can have very characteristic facial features. We will describe it in the next few slides. Heart condition, liver conditions, nutritional deficiencies secondary to fat-soluble vitamins, renal involvement, and also spinal or vertebral or musculoskeletal involvement, skin manifestations. So the estimated frequency is about 1 in 30,000 persons can affect equally males and females. So the cause for this condition is basically, it is, as I said, is genetic mutations in one of the gene called JAG1 gene, or like this is in the notch signaling pathway. I'm not going to go deep into this genetic details. Majority of the patients is about having this defect in the JAG1 mutation, but there is also smaller percentage, about 10% of the patients, they have a gene mutation in Notch2 signaling pathway. There's still ongoing genetic and research investigation regarding the development or evolution of this condition. I'm going to just start with a case presentations. This is a 7-month-old baby boy who was admitted to the pediatric unit with chronic persistent jaundice, abdominal distension, and severe malnutrition, failure to thrive since 1 month of life. They just basically looking at the child, physician noticed that there are some dysmorphic features, including broad triangular forehead, prominent ear, triangular face with depressed nasal bridge and bulbous tips of the nose. Physical examination showed that there is marked jaundice and there's marked organomegaly, which is including the liver spanning 6 centimeter below the costal margins, and the spleen spanning 4 centimeter below the subcostal margin. Several investigation was done, including liver biopsy, and there was approximately, as the pathologist report says, 25 portal areas were identified, out which only 4 portal areas shows well-formed bile ducts, while the rest shows absence or positive bile ducts, hepatocyte, focal giant cell changes, and intracytoplasmic cholestasis, lymphocyte infiltration, and fibrosis. This is a picture of the part of the investigations, including the X-ray of the chest or the spine, showing vertebral abnormalities. And this slide here is a histopathology. So a section of the liver biopsy shows portal venules, the black stars, and hepatocyte circling, and you can see that there is marked absence of the bile duct. The clinical feature for eventually this child was diagnosed with Alagille syndrome and underwent special consultation with hepatologist and ongoing liver evaluations. So going back to our topics, the Alagille syndrome, basically there are several clinical features, including multi-organ system. We'll start with the hepatic ones. So the hepatic involved is very common. Recent reports found it's only present in 89% of patients, and bile duct paucity in 75% of the patients. The severity of the cholestasis can vary from mild to severe, and liver enzymes are mildly elevated, except for the cholestatic markers, the gamma glutamyl transpeptidase and the alkaline phosphatase. Synthetic functions or synthetic dysfunction are usually rare, but it can present in severe fat-soluble vitamin deficiency and severe cholestasis. Serum bile acids are markedly elevated, even in the presence of normal bilirubin. The liver disease typically develops during the neonatal period with direct hyperbilirubinemia and elevated liver enzymes. There is, again, as I said, marked cholestasis and dyslipidemia, one of the hallmark for Alagille syndrome patients. So if you find a child under the 5 years of age with severe cholestasis, marked dyslipidemia, the prediction or the chance that this child will go on for sustained chronic liver disease is very high. In recent studies, the morbidity was much higher than previously reported, with 50% of children diagnosed with Alagille syndrome, they started to have complication or sequelae of chronic liver disease, including ascites. More than 25% presented for the first time with variceal hemorrhage secondary to severe portal hypertension, and only 20% of children who were diagnosed with Alagille survived with their native liver. It's usually present shortly after birth or early infancy or early childhood with persistent jaundice, irritability secondary to severe skin itching or pruritus, failure to thrive or severe malnutrition. Mild to moderate skin itching is present, and there are marked skin lesion on the extremities, on the joints. We call it xanthomas, or this can be very disfiguring, and it's not painful, but disfiguring and causing psychosocial worrisome. These are typically, we call it xanthomas, and it's secondary to the severe dyslipidemia. If you do a blood test on a child with Alagille syndrome, you see that there is elevated liver enzyme, markedly elevated alkaline phosphatase and gamma glutamyl transpeptidase, marked dyslipidemia, mildly elevated INR, conjugated hyperbilirubinemia, and markedly elevated serum bile acids. This is just a typical like features on the left upper corner here. You can see that the typical face, triangular face with prominent foreheads, and next to it is a skin lesion. You can see that the marked skin jaundice. These are the skin lesion, and it can be all over the body, can be very disfiguring, and also increase very poor quality of life. On the lower left-hand side, this is a normal liver histology. Next to it is a normal microscopic pictures with high-powered showing the portal tract anatomy or the histology for portal veins, hepatic artery, and bile ducts. Again, the hallmark feature for Alagille syndrome is bile duct paucity is the most consistent features. The gold standard diagnosis is basically the pathologist will look at the biopsy and will determine if there is the ratio of the paucity of the bile duct is consistent with the diagnosis for the Alagille syndrome or not. In a normal person, the normal bile duct to portal tract ratio ranges from 0.9 to 1.8. Dr. Alagille based his original diagnostic definition of the bile duct paucity as bile duct to portal tract ratio of less than 0.5 in an appropriate sample of liver biopsy. Appropriate sample means that the pathologist will require at least 10 portal tracts to be present on the liver biopsy sample. Some pathologists require up to 20 portal tracts in the liver biopsy samples. Ductular proliferation and giant cell hepatitis can also be present. The switching the gear to the other organ system, including starting with the heart, congenital cardiac disease is a very common feature of Alagille syndrome. Structural abnormalities found in about 94% of patients. Stenosis or hypoplasia of the branch pulmonary artery is the most common, followed by tetralogy of Fallot. However, there's a whole list of abnormal or congenital anomalies in the heart can be also present in patients with Alagille syndrome. Alagille patients with cardiac involvement have 6-year survival of 40%, comparing to 95% survival of those without any cardiac involvement. The presence of the cardiac involvement were noted to be more common in patients with JAG1 mutation than Notch mutations. The vascular anomalies or the vascular component of the Alagille syndrome, it's as I said in the first 2 slides, that it originally was named arteriohepatic dysplasia due to the development or the prevalence of vascular anomalies. Often leads to significant morbidity and mortality, accounting for up to 34%, secondary to the complication, especially in the central nervous system and the brain. Epidural, subdural, subarachnoid, or interparenchymal hemorrhage have been reported in up to 25% of patients. Also aortic aneurysm and coarctations, renal, celiac, superior mesenteric, and subclavian arteries and anomalies were reported. According to the protocol or standard protocol for following Alagille syndrome patients, these patients require MR angiogram to detect any vascular anomalies in the central nervous system, especially in the brain. And that's what's they have been detected in more than 30% of patients. It is recommended to have screening MRI or MRA once patient reaches the age where they can tolerate the procedure without sedations. Next to heart is most common renal involvement, and in the last few slides, I will mention that for the management of these conditions, fewer patients of Alagille syndrome will require combined liver kidney transplant secondary to the severity of the renal disease. So it is one of the consideration or one of the definition or this disease dividing criteria that's in order for Alagille patient to be diagnosed, a renal involvement must be present. Originally, renal findings were found in up to 74% of patients with Alagille. More recent report found renal involvement only 39 to 40%. The reason for this discrepancy might be related to the patient population of that study. The most common manifestations for the renal involvement is renal dysplasia in about 60% of the patients, renal tubular acidosis in about 9.5 or 10%, vesicular reflux in about 8%, and urinary obstruction in about 8.2%. The no associations was found between the genetic mutation and the renal disease, as I will describe for you in the next slide, because the both gene mutations have been involved in the renal development. Renal insufficiency, the need for renal replacement therapy or renal transplant is rare. All the patients should have a full functional and structural renal evaluations at the time of the diagnosis. This is just a cartoon for the kidney development during the embryo, and you will find that the Notch2 gene expressions starting from the beginning of the development of the embryo, and also the JAG1 mutations here in the development of the glomerulitis. The skeletal abnormalities are most commonly present in the vertebral columns, and one of the most common describes is called butterfly vertebra. Patients are asymptomatic and there is no structural significance caused by these abnormalities. It is one of the most diagnostic criteria in Alagille and found between 33 to 66% of the patients. The reason for this discrepancy, like between 33 and 66, because not all the radiologists will look for the evidence of the butterfly vertebra. So the wide range of frequency reported, because it is being misreported in up to 54% of cases read by the radiologist. Again, although it is considered one of the diagnostic criteria, it is not a defining diagnostic criterion, because this vertebral anomalies can be reported in other disease like Vater associations, the vertebral anomaly in perforate anus, tracheoesophageal fistula, and renal anomalies. Additional findings include the square shape to the proximal finger with tapering of the distal phalanges and extradigital flexion creases. Also, patients with Alagille syndrome have increased risk for bone fractures. This is a picture of the X-ray, and showed that this X-ray did not pick up. And when they did high resolutions X-ray or 3D X-rays, you can find the butterfly vertebra. This is like the slides we described before, like common facial features: the triangular face, prominent head, deeply set eyes, pointed chin. Ocular manifestations, one of the most again common features of Alagille syndrome is called the presence of posterior embryotoxin is the most common, found in 56 to 95% of patients with Alagille syndrome, but also people detected in 22% of children going to, in general, ophthalmology clinic. In order to secure the diagnosis, if the ophthalmologist found there is a posterior embryotoxin, they have to do what's called screening ophthalmic ultrasound on the optic disc, which can detect what's called optic disc drusen, which is a specific deposit on the optic disc, which is very, very characteristic for Alagille syndrome, found in 95% of Alagille and only in 0.3% of children in general ophthalmologic clinic. These are the pictures of the posterior embryotoxins in the left eye at the arrow and the right eye. The cutaneous manifestations is basically considered one of the hallmark for the Alagille syndrome, and it is believed to be one of the strongest indicator to refer the patient for liver transplant. Severe pruritus secondary to severe cholestasis and elevated serum bile acids, large generalized skin lesion called xanthomas, especially in the hands and fingers, disfiguring and debilitated in nature. The xanthoma are largely secondary to the severe dyslipidemia, severe scaly dry skin related to the fat-soluble vitamin deficiencies. Again, it is a major cause for disturbed sleep pattern, malnutrition, poor school performance, neurodevelopmental delay, and very poor quality of life. And the major determinant to modify the exception score for those waiting for liver transplant. These are the skin lesion, as I described before. You can see that how disfiguring is for the hand and on the legs. Growth and nutrition are basically very common in the Alagille syndrome patients with severe malnutrition, secondary to steatorrhea, which is secondary to cholestasis and malabsorption of fat for the absence of biles, and also secondary to the nutritional requirement to the muscle building and also for the fat. Neurodevelopmental criteria basically as a concern for children with Alagille, and there is a report that 30% of children they having an IQ less than 80, but more recent studies showed that this is a percentage is lower than that. Almost 50% of Alagille patients have some neurologic deficit due to and do receive special educations. Poor nutritional status and severe cholestasis are major contributing factors. To diagnose children with Alagille syndrome, that's we have to present with a child coming or a patient coming and you're suspecting that this child might have Alagille syndrome. Complete and careful history and physical examinations. We have to pay attention or pay high index of suspicious in any child with heart murmur and jaundice. These combinations directly led us to think about Alagille. Careful family history, if there is any family history, family members is affected by the disease. Detailed and complete physical examination, special attention to all the other organs we spoke about previously, and we go for the diagnostic studies. The diagnostic studies include blood tests to include complete blood count, chemistry, including the liver function test, lipid panel, serum bile acids, coagulation study, fractionated directed bilirubin, cholestatic markers, GGT, and fat soluble vitamin level. We need to get an abdominal ultrasounds, cardiology evaluations, including echocardiogram, renal ultrasound, and renal function test, and anteroposterior spine X-ray to rule out or to detect any vertebral anomalies, ophthalmologic eye or eye exam, nutritional assessment and genetic testing, we call it EGL panel, and finally the liver biopsy. The management, we have to pay attention to the nutritional status as a medical management for major clinical complaints, skin itching and steatorrhea. As the cardiac abnormalities should be cared for on an urgent basis, especially if surgical intervention is required. And finally, the role of the liver transplant. Nutritional status going back, so we have to supplement with high caloric intake with increased MCT to compensate for the fat-soluble vitamin deficiencies, using supplemental formula rich in this MCT oil. Placement of feeding catheters for those with poor oral intake is necessary. supplementation with fat-soluble vitamins, cutaneous manifestation, we have to take care of it very well so we can ease the life or the social life of the patients. Skin emollients topically, especially attention to nail hygiene, avoiding bathing in the hot water to help minimize itching and excoriations, Orsolil for bile flow stimulations, cholestyramine used as bile acid binding resin, but it has to be given 2 hours before meal. And the most recently approved FDA medication called IBAT inhibitors, which is ileal bile acid transport inhibitor for the severe itching. Liver transplant is a final and the cornerstone for the final treatment for all these kids. The approximately or initially thought to be 21 to 31% of Alagille patients require a liver transplantation. In a recent study of cholestatic children, they found out that 70% of cholestatic children with liver disease required liver transplantation during childhood. Indication for transplant includes severe pruritus, as we said before, as a major contributing factors, synthetic dysfunctions, portal hypertension, recurrent bone fracture, and severe growth failure. In few cases, combined liver-kidney transplant is indicated, and very rarely combined heart-liver transplant is indicated. I will stop here, and I'll thank all the audience for listening, and I'm ready to take any questions. I have some questions here by the audience. I can, one of the questions, I have 3 children. My youngest one, 12 months old, have been diagnosed.
If you don't mind, Dr. Yanni, please allow me to introduce the other 2 hepatologists who will be helping you with the questions. This was a powerful presentation. Thank you so much about a rare disease that we don't hear much about, but
My pleasure.
Yes, thank you so much. It was very powerful and very detailed, and I learned a lot myself. So now we will start the second half of the webinar, the roundtable conversation. We have 2 guest experts that will talk with Dr. Yanni about this disease, and will try to respond to the questions that have been sent to me beforehand. It is now my pleasure to introduce Dr. Patel to our webinar, to welcome Dr. Patel to our webinar. Dr. Yanni, I think you need to stop sharing your screen. Yes, thank you. Dr. Arpan Patel, MD, PhD, Assistant Professor, David Geffen School of Medicine at UCLA, Staff Hepatologist, West Los Angeles VA Medical Center. And I don't understand what this is. I tried to Google it. Dr. Patel, maybe you can tell us when you speak. CSHIIP investigator for VA Greater Los Angeles Healthcare System. Dr. Patel earned his medical degree from Jefferson Medical College, where he graduated summa cum laude and was awarded membership in Alpha Omega Alpha and the Gold Humanism Honor Society. He went on to continue his education and to complete his additional training in internal medicine, gastroenterology, primary care research, and transplant hepatology. In 2020, Dr. Patel joined the faculty at the UCLA Vakje and Tamar Manoukian Division of Digestive Diseases as an assistant clinical professor of medicine. Dr. Patel's research focuses on ways to improve the quality of life for patients with chronic liver condition, as well as their caregivers. His research has been published in a number of journals, including JAMA, Internal Medicine, Clinical Gastroenterology and Hepatology, Annals of Internal Medicine, Hepatology, Journal of Pain and Symptom Management, and Liver Transplantation. He is an active member of the American Association for the Study of Liver Diseases, AASLD. Dr. Patel is a member of the Liver Health Foundation's Medical Advisory Council. Dr. Patel, welcome, and thank you for your participation.
Thank you. It's wonderful to be here. And the CSHIP stands for the Center for the Study of Healthcare Innovation, Implementation, and Policy.
All right. I couldn't, I Googled it, but Dr. Google didn't respond to me. I am pleased now to introduce Dr. Sean Shandana. Dr. Shandana, GOFACP-AGAF, is attending physician in gastroenterology and hepatology at Olive View, UCLA Medical Center, associate professor of medicine in the David Geffen School of Medicine at UCLA. Dr. Shandana earned his Bachelor of Science in Microbiology, Immunology, and Molecular Genetics at the University of California, Los Angeles, or UCLA. He received his medical degree with honors from Western University of Health Sciences. He completed his residency in internal medicine and dual fellowship in gastroenterology and transplant hepatology at the University of Cincinnati. He is a board certified in internal medicine, gastroenterology, and transplant hepatology, and is a fellow of the American College of Physicians and fellow of the American Gastroenterological Association. Dr. Shandana has held faculty position at the University of Utah and the University of Cincinnati, where he was assistant professor of medicine. He served as assistant fellowship director for gastroenterology at the University of Cincinnati and co-developed the multidisciplinary liver tumor clinic at the University of Utah Huntsman Cancer Institute. Dr. Shandana is a member of the Liver Health Foundation's Medical Advisory Council. Welcome, Dr. Shandana. Thank you for your support.
Thank you so much for having me on, Farah. Appreciate it.
Thank you. I had put a question in my script that I can throw out, and then Dr. Yanni, you can take over from other questions. One of the questions was, please explain more about life-limiting and life-threatening aspects of ALGS. Dr. Yanni, would you like to comment on this question?
Yes. So the life expectancy, one of the slides, or in my presentation, showed that usually the severity of the liver disease is very, very intense in the first 5 or 6 years of life. If a patient or a child survives this period till beyond the 6 years of age without any complications, no heart conditions or very, very mild pulmonary stenosis, no limitation of activity, the synthetic liver functions are fine, mild liver disease with very mild symptoms. The life expectancy is basically, I'm not saying going to be as completely normal life, that you need to be follow up with adult hepatologists when they reach adulthood for continuation of care. But the life expectancy can continue. We have, I have a family, a mother and her daughter, and I know that the mother was diagnosed with Alagille, and she, unfortunately, she got married and she has a daughter, and the daughter was also diagnosed with Alagille. So I'm following the daughter, and she's following the adult hepatologist.
Thank you. Dr. Patel, Dr. Shandana, do you want to add something, or should we move to the next question?
Yeah, I actually just had more of a follow-up question for Dr. Yanni. You know, as adult hepatologists, we're going to be seeing a lot more of these patients. I think that get followed from the pediatric setting. And I was just curious to see, do a lot of the manifestations that you were discussing, the cardiac and renal, are these more things that are present at the time of diagnosis, or do you really mostly see them? Can they develop later during the course of illness, like let's say going into adulthood? I was just curious about what your experience with that was, Dr. Yanni, just as a follow-up question.
Well, my experience was like once poor it rains. So if like the liver disease is severe at the beginning, you start to see other complications. Fortunately, the heart condition, if it is so severe, if there is severe pulmonary stenosis, require heart surgery. They can correct the manifestation later on if the liver disease is mild. We have patients went and have they corrected their heart condition. That severe pulmonary stenosis can lead to pulmonary hypertension, and this can aggravate or exacerbate the liver disease. Once this is corrected, the severity of the liver disease can be easy enough for the patient to survive. But we see also some other patients survive till the teenage years, and we just transplanted a patient combined liver kidney at age 14 3 years ago. Because but I think that patient was also missed out or failed to follow up, continue to have ongoing problems that have been not detected. So it's these patients, once diagnosed, they need a very close follow-up to make sure that they don't deviate from the regular pathway. Like if you, it is exactly the same as for Fontan patient. Now you're seeing more patients graduated from the cardiology clinic with hypoplastic left heart or hypoplastic right heart who underwent Fontan surgery. And this Fontan surgery, now there is a new entity, Fontan-associated liver disease. And starting to see these patients starting to, in the past, people said Fontan patient cannot live beyond 25 years old. Now you're seeing patients 42 or 50 years old with Fontan and still living. So the technology and medical management are developing every hour, and medication have been developed concurrently to treat the major symptoms. The newly FDA approved IBAT inhibitor, Livmarli, was a major determinant in easing the skin itching, and lots of patients, they're feeling happy. They measure bothering some issue had been released. So it all again, just close follow-up. You cannot leave the patient without follow-up.
Yeah.
This is a really complex disease that affects so many parts of the body. So one of the questions, Dr. Yanni, you were reading that. Do you want to start with that, or do you want me to read it for you? The first question, it was it says, I have 3 children. My youngest one, 12 months old, has been diagnosed with ALGS. We were hoping to have another child. Should we, both me and my husband, have gene testing now? Our 2 other kids are normal with no ALGS symptoms. Should we have them undergo gene testing to make sure they're not carrying the changed gene? This is a multiple question. What are the other tests that may be available to us? If our other 2 children are carrying the gene, is there anything they or doctors can do to stop their future children from having ALGS?
I mean, it is a very complex and it's really a very sensitive issue. Definitely, everybody in the families, you have to get genetic testing because you need to make sure that nobody carrying the gene. It is an autosomal dominant. So if for those who are like not having any or not diagnosed with Alagille, so most likely they don't have it at all because if the gene is present, means that the disease is present. This is what autosomal dominant means. So, but to make sure and to have a peace of mind, I think the whole family need to be tested genetically. For those who carry the gene or who are affected, but this is again there is a higher percentage compared to normal population to have children affected with a disease. Yes, this is a risk, and it is up to them to follow with they need to follow genetic counseling to let them know exactly what they're supposed to do to for their life.
Dr. Yanni, I have a follow-up question for you. So this seems like a very variable phenotype in terms of multi-system organ involvement, but since it is autosomal dominant, is there essentially penetrance with all patients, even subtle, subtle characteristics or subtle abnormalities? Is everyone going to have at least one manifestation of Alagilles if they have a pathogenic variant?
Like a varying penetrance, and this is actually can explain why some patients they live without any complications, and why some other patients they have suffering from day one. So we have children like they are diagnosed with Alagille syndrome. We are following them, and basically they are growing, although in the lower pace, but they are following the growth curve. They don't have any major abnormalities. They have some settled like symptoms, mild itching here and there. Their enzymes are not completely normal. They have normal bilirubin. Their serum bile acids are mildly elevated. So as I said in one of the first few slides, ongoing research and investigations are always underway. We have our scientist, our division chief, Dr. Coley, is one of the expert in the field in bile acids and the bile acid metabolic disorders and the ductal plate malformations. There are so many other great scientists in the field. They can give feedback about this, but clinically, once these children or these patients are diagnosed, they need close follow-up with a hepatologist or gastroenterologist to make sure that they are not deviating or there is nothing going on with them.
I had another question, kind of because of the fact that we'll likely be seeing more of these patients as adults. I'm curious about, how to reduce the risk of some of the other organs that are going to have disease, specifically the bones. These patients, like you were mentioning, are at risk of fractures. And I was just wondering what your thoughts were about any specific nutritional recommendations or monitoring of osteopenia or osteoporosis that could increase risk of these patients having fractures, if any of that's known or if there's any sort of standards to that practice.
With these patients, they are coming to the liver clinic or the hepatology clinic. They also follow up by dietitians and social worker. This is a multidisciplinary team clinic. This is why I said they need to be closely monitored for their level of fat-soluble vitamins and make sure that their nutritional status is optimized. The bone health is very, very important. They have to try to be to avoid any special kind of trauma. You're not expecting a child with Alagille syndrome to be a professional football player or because the intensity. They need to be completely followed up, and also not only the bone health, they are required to follow up their neurological development and also their central nervous system. Once they reach an age for MRI study, they need to have the MR angiogram to make sure that there is no brain aneurysm or no vascular malformation throughout the body.
So I'm going to piggyback off of a question. I'm going to ask the question and I'm going to ask a variant of it as well. But one of the questions was, what are the newest treatments for itching for Alagille syndrome? And my question for you, Dr. Yanni, I know there's maralixibat, there's another medication as well. I think it's odevixibat for pruritus. But can you comment a little bit about your approach to pruritus, the management of it? Do you start everybody on ursodiol? Do you escalate appropriately? Do you use IBAT inhibitors first line? Do any of these change the pathogenesis or the disease course, or are these only symptom management on a pruritic level or maybe on a liver chemistry level?
I think Dr. Yanni might be muted.
Oh,
sorry about that. So we know that the mechanism of the skin itching or the pruritus is like mainly related to the marked elevation of the serum bile acid, which is very irritant to the skin. So in the past, like 30 years ago, they used to have this ileal diversion surgery. They have that we have patients. They have actually outside their body bag to drain all this bad bile outside of their body and gives them ursodiol as a supplement. With the development of all these new medications, bringing the ursodiol, which is bile flow stimulants, and making the passage of the bile through the liver is much easier. Now the development of this like IBAT inhibitor, you're decreasing the preload of on the body from all these irritants. So we've seen patients responding very, very well to maralixibat. So the itching score went way down based on the clinical examination for the patients. The other medication is designed for the entity called PFIC, or progressive familial intrahepatic cholestasis. So for Alagille, the treating the pruritus is as we saw patients with responding decrease in the bile acids level in the blood, which is a marked improvement. But is this going to be a cure for the disease? I don't think so, because if the liver synthetic function is intact, I would say yes, this is a major advance, and we can hope for the child to grow without the need for liver transplant. But if this is not, if there is already a liver cirrhosis and there is a complication of the liver cirrhosis or liver marked fibrosis, ascites, portal hypertension, severe malnutrition. So this patient need to be like transferred or referred for liver transplant.
Some of the questions we had were from parents whose children are suffering from malnutrition, and they said no matter what we do, especially when they take vitamins, because their body cannot absorb them. When they take vitamins, the kid either goes through a circle of diarrhea and vomiting and just cannot hold anything down. So it seemed to me like nutrition is a very huge issue for these children.
I would like to make sure that these children are followed up by a hepatologist or multidisciplinary team clinic, including the dietitian, because we would like to optimize the nutritional status by all means. So this means that if we need to place a feeding catheter to give them nutrition, we have to do that. If we need to start them on parental nutrition to increase their caloric intake and to help their nutritional status and their vitamin, like the fat soluble vitamin deficiency status, we can do that. When all these fails, this is a major indication to refer these children to liver transplant, because as I said in the last slides, that's one of the indication for liver transplant is severe severe malnutrition, and basically the child cannot survive without a transplant.
Thank you so much, Dr. Yani. And I want to finish our conversation in this part of the program with a positive note we have received from a patient. He says, I'm 32 years old and living with ALGS. Despite my health issues, I'm still alive, working and making a moderate living. My wife and I have adopted 2 great kids, but we have no biological kids for the fear of passing along my disease to my children. I don't know what my life expectancy is. It changes from time to time on how I feel about my future. But I am happy to be here. I am happy to be alive. I think that is a good place for this person to be, and a positive note for us to go through the final part of our conversation today. So this was a wonderful conversation. Thank you for all of your questions. And I just want to say another thing here is that I want our audience to know that our presenters, our doctors are here as volunteer physicians. They care deeply about liver patients, about you. They use their own personal and family time and share their expertise with all of you in support of our efforts in helping liver patients and raising awareness of liver disease. So my personal heartfelt appreciation to our doctors for their kindness and compassion. Thank you, Dr. Yani, for your great presentation and the information you shared with us. We are grateful to have your support. Thank you for being a wonderful friend to Liver Health Foundation.
Thank you, Farah.
Thank you. Thank you, Dr. Patel. We go a long way. I knew you when. We lost you for a little while as you were continuing your education. We are happy you're back, and we are proud to have your continued partnership with the Liver Health Foundation.
Thank you, Farah. Appreciate it.
Thank you, Dr. Chandana, for accepting our invitation and participating in this webinar. We are looking forward to working more and more with you in 2025. Thank you. We want to thank our sponsor, Ipsen Pharmaceuticals and Mirum Pharmaceuticals, for supporting this webinar with their educational grants. We couldn't do this without their support. Later this month, Liver Health Foundation will host an educational webinar on primary biliary cholangitis, or PBC, and primary sclerosing cholangitis, PSC. These are 2 rare genetic liver diseases. One of them impacts women more than men. For more information and registration, please visit our website, liverhealthfoundations.org. Liver Health Foundation is on all social media sites. Please visit our social media sites, leave messages for us, and see our notices for our upcoming programs. Thank you again to our doctors and to our sponsor and you for joining us this evening for this important webinar. We wish you a lovely Valentine's Day. May your life be always filled with love, roses, and chocolates. Be well, take care. Thank you, and good night.